All right, welcome everyone to the show today. We have Dr. Robert Goodman, who's a neurosurgeon at Hackensack University Medical Center and has been an innovator in the treatment of epilepsy for more than 30 years. He established one of the first multidisciplinary epilepsy centers in New York City as a faculty member at Columbia. He's a scholar and has over 100 peer-reviewed publications to his name. After completing his medical education at Johns Hopkins University, he went on to complete his neurosurgery residency at New York Presbyterian, Columbia University Medical Center. He later completed his fellowship training in epilepsy surgery at the Montreal Neurological Institute. Today, we're going to be speaking with Dr. Goodman about responsive neurostimulation, also known as RNS, and deep brain stimulation, also known as DBS.
So, Dr. Goodman, thank you for joining us. And I owe a lot to Dr. Goodman. He's been a mentor of mine, and I've had the great privilege of getting to work with him and learn a lot from him. So today we're going to bring him in to talk about, as Rohit mentioned, specifically DBS and RNS for epilepsy. In 2013, NeuroPace was first FDA approved in the United States, and since then it's been widely applied to the treatment of patients with partial focal epilepsy. Can you describe the basic principle of reactive neurostimulation and tell the viewer a little bit how it works?
Yeah, it's always difficult to know how things work in medicine. And actually, I think it's helpful to talk about how this device was developed.
Sure.
It was the first concept of it came from some innovators that had developed a cardiac device for an implantable device to stop arrhythmias in the heart. So after they had developed a successful device, the guy who had developed it was wondering if they might be able to do something similar, a similar idea to treat epilepsy, seizures. The idea actually came from an observation that was made in a single patient that was having brain stimulation done, an epilepsy patient, and had stimulation done to try to identify functional areas in the brain. And we have always known that when we stimulate the brain, we might actually produce a seizure instead of just stimulating to try to inactivate an area that's being stimulated. And that happened in this one instance where the brain was being stimulated. It started to kick off a seizure, starting right from where the spot that had been stimulated. And then what they did is they delivered the same stimulation to the same spot right after the seizure started. It started electrically, of course, so they were watching it on EEG or corticography. And that after the next stimulus, it stopped the seizure propagation. So that observation was published, and then this gentleman who had developed the cardiac device thought maybe a device could be developed that would be implanted in people with epilepsy and have the electrode sitting in a spot where a seizure was going to start, detect the beginning of a seizure, and then deliver electrical stimulation to that area and possibly stop that from spreading and becoming a clinical seizure. The idea at the very beginning was that in most patients that have focal onset seizures, the seizure starts in an area of the brain electrically without causing any interference with brain function, without causing any symptoms. People don't know that it's starting, but then it propagates, it spreads. And once it spreads enough, then it becomes a seizure that affects somebody's functioning. And it can be all sorts of different kinds of seizures. It could stay as a focal seizure, but it could also spread and become a seizure that impairs people's awareness, or even a generalized seizure with shaking. But the idea was that if you could have a device sitting at the very beginning of a seizure and identify it and deliver electrical stimulation, that it could prevent that seizure from becoming, the electrical seizure from becoming a real seizure, a clinical seizure. And that the idea that the company was actually initiated in 1997 based on this concept. And I actually started working with the company when they first started working on developing the device. It was actually in 1999 when I was at Columbia. In the beginning, the first few years, what we did is we had patients implanted with electrodes, and we would record their seizures, and then we would try to simulate what we would do with an implanted device. We simulated it with an external system. So we would deliver stimulation to the brain in an area that looked like it was the beginning of a seizure. And we showed that it was safe to do that. And we also made some observations where it seemed that in certain cases we might have been preventing an electrical seizure from propagating, from developing. Well, it was limited in observations because each patient had an implant for a relatively short time and very limited number of seizures that we were able to see, but it was enough that our experience was used to develop the device. And the device that was developed is actually the same device, almost the same device that's implanted today. It's certainly the same device that was approved in 2013. There have been some improvements since then, but it took from about 2002 or 3 when the first device was created until 2013 to actually finish a trial that demonstrated that the device was effective, it reduced seizures and also was safe, and the FDA approved it. But it turns out that from our extensive experience using the device, that it didn't work in patients the way we had originally hoped that it would work. There are very, very few patients that there are patients that have seizures that behave like that original observation, where we have a device that we implant that has, it unfortunately is somewhat technologically limited. It's a device that can only have 2 wires connected to it, and each of those wires has 4 contacts. So those 2 wires have either 4 contacts that go penetrating into the brain or 4 contacts that sit on the surface of the brain. We can use either kind. And so those 8 contacts have to be strategically placed in the brain, and then they can the device is able to record continuously the electrical activity coming from those 8 contacts. And we have to place these contacts where we have identified a seizure onset to occur. And we can actually use it in people that we think have 2 different seizure onset areas, because we can place one electrode in one area of one seizure onset and the other one in the other area. And then that allows us to constantly monitor the electrical activity and see when a seizure is happening, and then to use the device to deliver electrical stimulation. It can actually be delivered in a fairly significant volume of tissue. It can be delivered through all of the 8 contacts that are sitting either in or on the brain, and also can use the device itself to be part of the circuit to try to spread the current into the brain. But what happened was it didn't actually work in stopping every single seizure from becoming a clinical seizure. But when we did the trial to prove that this device was effective, what we learned was, in a very short period of time, just a 3-month period of observation, using the stimulation, patients had decreased frequency of seizures during that time. So it somehow decreased the frequency of their seizures. That allowed us then to have that allowed us to get approval, actually, ultimately, of the device. But we also had much longer experience using the device, where it wasn't being compared to people that didn't get stimulation. It wasn't a comparison trial, but it was patients that had the device implanted, continued to have it used. And actually, we developed years of experience with all these patients that were implanted. And we found that over time, patients continued to have further improvement. Many patients continued to have further decrease in their seizure frequency. And we also found that certain patients had a complete elimination of some of their seizure types. In some cases, it was the worst seizure type that they had, the most disabling seizure type, stopped occurring and completely. And actually, there's some subset of patients, percentage of patients, that had no further seizures at all. It was not a large percentage of patients. It turned out in a long-term study that 18% of patients stopped having seizures completely. But the improvement of the seizure frequency seemed to happen very gradually over a long period of time, may be related to adjustment of the device's settings, because we have a lot of options for how we use the device once it's implanted. We can have it change the way it detects the beginning of a seizure to change when it delivers a stimulus. We can change where the stimulation is delivered in the brain. We can change how strong the stimulation is. So there are a lot of options for trying different things. And over time, with each individual patient, we can learn what setting is best for them. So that is probably one reason why some patients continue to improve over a period of months and years of having the device activated. But another possibility, and what we think is likely happening, is that it alters the brain behavior over a long period of time, that we consider this to be a modality that modulates brain behavior, that stimulating the correct area of the brain, possibly not absolutely necessary to time it specifically to when the seizures occur. It could be that stimulating the brain periodically, the correct part of the brain where the seizure problem is, somehow alters the behavior of that part of the brain over time. And ultimately that part of the brain reduces its tendency to cause seizures to occur. I mean, that's important as far as learning how the device has been used to help people with seizures, at least reducing their seizures. But there are other aspects of the device that are important to know. It's important to know that the device can be implanted with very low morbidity, very low complication rate, that the idea of the device is that it can be implanted without damaging any brain, removing any brain, and the stimulation is adjusted so that patients aren't aware that they are getting stimulation, and the stimulations are very brief. They do not affect brain function. When patients are getting stimulated, they don't know they're getting stimulated. We can adjust it so that we make sure that they aren't aware of it. And the other thing, which is, I mean, two other things about the device, which I think are also important to know, is that it can be helpful to use the information that we get from the device to adjust and optimize a patient's medication. Because the device monitors, it's a continuous EEG, and it's coming from the area of the brain that's most active in causing a patient's seizure. So by seeing how active that area is in spiking, which is in between seizures, it's happening all the time, it's clear that spiking reflects a tendency to have seizures, and that a medication that is effective reduces the frequency of spiking. So
what you're saying, if I could just interrupt for a second, is traditionally neurologists are looking at scalp EEG to try to understand how to titrate medicines. But here, in fact, you have a much higher quality implant that's allowing you to see the effect not only of clinical seizures, but of the EEG activity.
Yes, and it's not even just a huge advantage over scalp. It's continuous. It's there 24 hours a day. You can add a new medication, try a new medication on a patient, and within a week they can see changes in an EEG that would indicate that that medicine is actually is changing things in a positive way. So they can make a rapid decision about whether a new medicine is likely to be helpful to a particular patient. In general, you have to wait and have a report of seizure frequency, try to figure out if that new medication is actually reducing their seizures, and it's a much longer process. So many neurologists are using the device to help them quickly decide on a new medicine if it's effective. And the other thing, which is a large subgroup of patients that have this device implanted, have it implanted because they have a seizure problem that looks like it could be coming from both of their temporal lobes. Could be other areas, but one of the most common situations is where people have both of their temporal lobes look like they could be causing some of their seizures, but it's not clear if seizures are independently coming from each temporal lobe or possibly not. Plus, sometimes one temporal lobe is more able to cause seizures or more of a problem for the seizures than the other one. And so one temporal lobe might respond to a certain medication regimen and the other one won't. By having this device implanted and monitoring from both temporal lobes over a long period of time, many patients have been identified that turn out to have all of their seizures coming from one temporal lobe. And then sometimes they become a candidate to have a procedure done to completely eliminate their seizures, because they could be a candidate to have sometimes a minimally invasive procedure, sometimes a traditional surgery to remove the area of the seizure area and become seizure free, because we've now learned that their seizures that are refractory to medication are all coming from one temporal lobe. Sorry, long answer to your question.
No, that's great. I'll tell you, it's really fascinating to have you for this topic, because you were on the on the forefront of creating this technology and had a role in that. So it's really a fascinating background. Thanks for talking about all that. With all the experience that you have, and you've now seen this technology, how it works in a number of different patients, how would you start to describe to somebody who is you mentioned bitemporal epilepsy, but who is a good candidate? Who might be, if you could describe the ideal candidate for NeuroPace, how would you describe that?
It starts with a patient, almost pretty much exclusively patients that don't have their seizures completely stopped by medication. It's rare that there would be any other reason to do it, and certainly those are the only patients that it's actually FDA approved to use for. So
Sure.
First, it has to be a patient that's been tried on 2 different medications to try to stop their seizures, and they continue to have seizures. The other thing is, it has to be a patient who we think has their seizures coming from 1 or 2 foci, places in the brain. And we can get that information sometimes from regular evaluations that include scalp EEG, MRIs, PET scans, the kind of evaluation that we do of patients that might become candidates for a surgery to try to cure their seizures, because maybe we will identify an area of the brain that appears to be the source of their seizures, that also appears to be an area that's not providing critical function, so it could be removed surgically and have an excellent chance of curing their seizures without causing an impairment of neurologic function. But it turns out that many of patients that fit into that scenario, turns out that we identify an area that appears to be the source of their seizures that we might feel that it's too risky, or we might be fairly confident that that area is also providing important function. And if we were to remove that area, it might eliminate seizures, but it might also cause an impairment of function that would be bothersome, unacceptable. And so in those patients are the largest subset of type of patient that's a candidate, is a patient where we don't recommend a resection or an ablation of what we presume to be their seizure onset area. And like I said, some of these patients end up being patients where both temporal lobes appear to be involved. And so we are still generally implanting the device because we don't think that we can perform a resection and have a high likelihood that a resection or an ablation is going to eliminate their seizures completely, because it looks like in the patient with both temporal lobes involved, if we do something in one temporal lobe, then we think they're likely that they're going to continue to have seizures from the other temporal lobe. And in general, we don't recommend an ablation or a resection in a patient unless we have a significant chance of complete seizure control. Gotcha. And I hope that answers the question.
It does.
Thank you, Dr. Goodman. So you mentioned how RNS has a place prior to surgical resection. Are there any uses for it in conjunction with surgical resection?
Yes, I haven't mentioned that many patients, before we recommend responsive neurostimulation as a treatment, they've gone through another phase of evaluation for a possible resection, besides what I just mentioned, the kind of tests that are non-surgical or non-invasive tests. A lot of patients where we think they might be a candidate for a resection that will be able to cure their epilepsy, the only way we can recommend a resection is by first doing an invasive evaluation, an invasive EEG evaluation, putting in electrodes, touching the brain, that will allow us to monitor seizure onsets, and I try to identify the area where the seizures are starting. And also sometimes we use those electrodes to identify areas of important function in the brain, to know if the area that appears to be the onset area is very close or overlapping with an area that is an important functional area. So those patients, there are 2 different approaches that we use. One is, which has become the most common one, is putting multiple depth electrodes that go through tiny holes in the the bone and the skull that are placed strategically and very accurately into specific target areas in the brain with multiple contacts in the brain. Stereo EEG, that would be. The other option would be electrodes that sit on the surface of the brain, which could be grids, arrays of electrodes that cover an area of the surface of the brain, or strips that cover areas that are possibly on the undersurface of the brain. But with those electrodes implanted, we might identify an area that we would recommend for a resection. So if we do that and we do a resection, very often we have a very high, we expect that resection will have a significant chance of eliminating seizures. And so that's the typical scenario. In those cases, we would do that surgery. We've already learned a lot about that particular patient's brain and their seizures, their function, but we would do a resection hoping that it would eliminate their seizures. But whenever we do that, we know that the chances of completely eliminating their seizures, it varies somewhere between 30 and 70%, depending on the exact details of an individual patient. But many of those patients are not cured of their epilepsy by that resection. But in some cases, it's because we purposefully did not remove the entire area that we were suspicious of that was involved in the seizure onset, because we felt it would be risky to do that it could cause an impairment of function. And so those cases, many of patients that have had responsive neurostimulation implanted are patients like that have had an investigation using invasive electrodes that will really learn and map their seizure problem, where we think that there is still a residual area of the brain that was involved in their seizures that we did not remove. We know where it is. We know where their function is. And so many of those patients were the ones that would undergo an implantation of a responsive neurostimulator device, where we could put either strips or depth electrodes into areas that we previously identified as being the best targets for having the RNS device.
It's good. So let me summarize a little bit. You've talked about bitemporal epilepsy is a good candidate. You've talked about patients who have multifocal epilepsy, perhaps coming from eloquent areas, who can be treated upfront with neuropace, or who could be treated partially with resection of safe areas to resect, and then the RNS can be implanted in those areas that couldn't be resected. I'm actually curious. Increasingly, there's a lot now in the literature, and we've talked about this some, about RNS being used with thalamic targets. And I guess I'd like you to talk a little bit about the thalamus, just your thoughts about the thalamus as a seizure generator. Maybe you can start there, and then talk about what do you think about RNS being used for kind of regional, hard to localize epilepsy with thalamic targets?
Yeah. I have actually used that in some patients myself. We're very early in our experience with using responsive neurostimulation in the thalamus, but there are some very promising results in certain types of patients. And there's, I'm sure, a lot more that we're going to learn about the possibility of targeting the thalamus as part of our strategy for helping patients with epilepsy. As far as these particular type of patients that we've already discussed, we know in many cases their seizures become symptomatic, or their seizure spread through the brain involves parts of the thalamus, and we certainly have some evidence that including an electrode in the thalamus in some patients is very useful for identifying when a seizure has started, because many patients turns out that a target in the thalamus is activated very early in the seizure spread. So it can be very helpful as a detector of a spread of a seizure.
Before cortical involvement in some cases.
Well, either simultaneous to it and sometimes before symptoms start. So it could be that cortex is involved somewhere, but it could be one of the earliest identifiers of a seizure onset. But also, there has been some experience that stimulation, including the thalamus for stimulation, has helped in certain patients to reduce their seizure frequency. So that what I'm talking about right now are patients that are like the ones we've been talking about up till now, patients that appear to have their seizures starting in an area of the cortex and then spreading from that area or two areas maybe. There's also, and this is still very early in fact being pursued as part of an investigational trial with a responsive neurostimulator, is patients that have been diagnosed as having idiopathic generalized epilepsy or Lennox-Gastaut syndrome, where the seizures, those patients, especially patients that have convulsions that are not completely controlled by medication. It can also be patients that have complex partial seizures or not necessarily convulsions, or seizures that involve impaired awareness without violent motor activity. But the patients that may turn out, and the early evidence is that patients that have tonic-clonic seizures, generalized convulsion type of seizures that are not controlled completely by medicine, and those seizures can be very morbid for patients to have, and sometimes are fairly frequent and cause bodily injury, are very risky to have. There are a large percentage of the patients that have been treated so far with RNS, responsive neurostimulation, including the central median thalamus as a target. There have been a very significant percentage of those patients that have appeared to have responded with a dramatic decrease in their seizure frequency, and some that those tonic convulsions have stopped completely. So it's still early and it is part of a trial, but I've used it in some patients already when we think that it could be useful. And one thing that people are starting to do, and we're starting to do this now, is to, as part of the SEEG evaluation of patients, to target the thalamus with electrodes that we're using also for the cortex to record from the cortex. We can advance some of those contacts into areas in the thalamus, like the two areas that are the most suspicious for being involved in seizure spread, the anterior nucleus of the thalamus and the central median thalamus, that we could actually place electrodes into those areas and in an individual patient record and see which, if either one of those areas or both of those areas are involved at the seizure onset, and whether they might be a good target potentially down the road for a responsive neurostimulation.
So a way to use SEG to really tailor these thalamic placements. It's very interesting. Let's switch gears a little bit and talk about DBS. Rohit, you wanna start us off there?
Sure. Dr. Goodman, deep brain stimulation, also known as DBS, is a pretty well accepted technology for the treatment of patients with tremors and Parkinson's disease. In 2015, you were a co-author on the article from the SANTE study group showing the efficacy of DBS of the anterior nucleus of the thalamus for patients with focal DRE. Can you tell us about the study and how we think DBS works to control epilepsy?
Yeah, you go back to that same question again. I can only say that with the anterior thalamus, there was a lot more evidence in various animal studies, actually, and some human studies, but mostly a lot in animal studies, to indicate that the anterior thalamus has broad connections to the limbic system, and the limbic system is involved in seizures in a large percentage of patients. And there was some experience that in certain models that simulate epilepsy, that stimulation in the anterior thalamus improved the EEG, or decreased seizures, or stopped seizures, reduced the duration of seizures, or severity of seizures. So there was a fair amount of evidence that it could potentially be an effective target to deliver stimulation into the anterior thalamus on a programmed basis. Put an electrode there and then program it to deliver stimulation basically identical to what we have done with DBS in treating patients with Parkinson's and tremor, going back to the actually late 1980s. And so the idea was that type of stimulation in the thalamus, because of its broad connections to the areas of the brain that are clearly involved in seizures in many patients, and because of the evidence that stimulation seemed to reduce the tendency of those areas to produce spikes and seizures, that it would be useful. So that was the concept. And turns out, which is really somewhat surprising, the study that was done with that study you referred to see if stimulation of the anterior thalamus was going to be effective for seizures was formulated in a way very similar to the study that we did on responsive neurostimulation. They both had a period of time, 3 months, where stimulation, every patient was implanted, but only half of the patients, I forget it was half, might have been 2/3, but a certain percentage of the patients had the stimulation turned on, and then some did not have it turned on for 3 months to give a chance to see if the stimulation changed the seizure frequency. It's the same thing we did with the responsive neurostimulator system, and they both had very similar results. They reduced seizures in a very similar way. The problem with the anterior thalamus study was that one of the patients in the study had 100 seizures, or a huge number of seizures in one day when they had changed the stimulation parameters. And that result of that one patient made it so that their study didn't meet the goal that they had for the study to prove that it was effective. And if they had removed that one patient, then the study proved that it was effective, similar to the responsive neurostimulator device. But because of that happening, there was a long delay in getting approval. They had to do other studies. That was approved in Europe, and there was experience with it. So it delayed the approval of DBS in the anterior thalamus for epilepsy. But then it was approved in 2018, I think it was, and it was approved. The only slight difference from responsive neurostimulation is that patients still would be patients that we suspected to have a focal onset for their seizures. Somewhere in the brain, there's a focal onset, and then it spread, not primary generalized epilepsy. And the other thing is that they had to fail 3 medicines instead of only 2. So, but basically very similar patient population to patients that could be candidates for responsive neurostimulation. But the results as far as improvement of seizure frequency were almost identical to their experience with responsive neurostimulation, that the initial reduction is in the range of about 40% or 50% of patients have a significant reduction of their seizure frequency, but over a period of years with ongoing stimulation,
it improves with time.
It improved to about the same level, to about 70% of patients having an improvement, a significant reduction of their seizure frequency. It's not clear why such different approaches would yield such similar improvements, but they do.
So we're going to wrap it up in a little bit. Give us a few sentences about, because we sort of switched from RNS to DBS. These are both methods of stimulating and modulating brain activity through neurostimulation. Give us a few sentences on the difference between open loop and closed loop stimulation.
Yeah, I thought that's where you were going, and we didn't. I don't think we may not have talked enough about that. What RNS does. First of all, another thing which I think it'd be good to mention about responsive neurostimulation is the way the device is implanted. That the device itself is implanted in the skull. We actually remove an area of the skull that allows us to put a metal tray in place of the part of the skull that was removed, and that metal tray holds the device itself, which is a computer and a battery that has the wires connected to it. So it's under the scalp. It sits where the skull used to sit. People have generally do not have a noticeable visible change from having it implanted. But the difference is, which I referred to before, is that the responsive neurostimulator device allows us to continuously record the electrical activity from the areas of the brain that we suspect are involved in the seizure onsets of that particular patient. And that offers incredible information. Like I mentioned before, it actually allows us to learn a lot about that particular patient's seizure problem, their brain, and to see if it responds to medication. Over time, there's all sorts of information you can get. You can actually see patterns over a period of weeks and months and years of when a patient has their seizures. Sometimes patients have a very predictable pattern. They can learn from this when they're likely to have a seizure, based on how their recording changes. And every day that data can be downloaded and can be observed by a treating neurologist to see what's going on in that person's brain. That's not available with the DBS system. The DBS system is a device that we can program to deliver stimulation to the brain, and it generally delivers stimulation in basically 24 hours a day. It's delivering stimulation, not all the time. It's adjusted so that there's a certain frequency, but it's giving stimulation continuously almost based on, and the parameters can be adjusted, but we don't get feedback from the device as far as
so a continuous
seizures.
as opposed to basically a tailored
Knowing
stimulation.
about seizures. And one of the things about epilepsy, which also, I mean, most people that have epilepsy or deal with patients with epilepsy know about this, that having to rely on a patient or other people observing seizures and counting seizures is not an extremely reliable system for knowing how often a patient has seizures or what their seizures are like. And having a device that's able to actually record and tell us when a patient has had a seizure, get a much more accurate idea of the seizure problem that a particular patient has and how it changes over time.
Great. Well, Dr. Goodman, we're going to leave it there. We are going to have you back to talk about temporal lobectomy, but thank you again so much. Really fascinating talk.
Okay, thanks.
Thank you, Dr. Goodman.
Thank you for listening to the Epilepsy Podcast. The video content and audio content is not intended to be a substitute for professional medical advice. The views and opinions represented here are merely the views and opinions of our expert guests. Thank you.